Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friend. Welcome to another episode of the Healing Pain Podcast. We have another incredible interview in our Radical Relief series, which we've been running all through the month of January and February. The Radical Relief series focuses on practitioners, academics, and researchers who are using 3 time-tested and evidence-based approaches for the treatment of both physical and mental well-being with a focus on chronic pain. So we're covering pain neuroscience education, mindfulness, and acceptance and commitment therapy. On today's episode, we're really zeroing in on acceptance and commitment therapy for the treatment of mental well-being. On today's episode, you will meet ACT psychologist Dr. Lilian Dindo. Her career has been focused on developing pragmatic and innovative ways to improve the mental health and functioning of patients suffering from psychiatric and chronic medical conditions. Through her research and development of applying a one-day transdiagnostic acceptance and commitment training presented as a workshop, she has found this to be less stigmatizing than traditional therapy and also ensures treatment adherence and completion for people suffering with both physical as well as mental health issues. Dr. Dindo has been involved in several clinical trials examining the efficacy of one-day ACT treatment workshops, which have included those who are suffering from chronic pain, traumatic brain injury, orthopedic surgery, migraines, depression, anxiety, as well as post-traumatic stress disorder. On today's episode, you'll learn how to conduct a one-day ACT workshop, the acceptability of this type of approach, as well as the positive outcomes, and why this approach may be soon competing for the evidence-based gold standard treatment for the effective treatment of mental health due to its amazing completion rate. If you are a mental health professional or a physical medicine professional, and you're interested in learning more about acceptance and commitment therapy and how you can create your own workshop, make sure to check out my book, Radical Relief, A Guide to Overcome Chronic Pain, which is deeply rooted in the principles of acceptance and commitment therapy. One of the key reasons I wrote Radical Relief is so that you, the clinician or the practitioner, would have a manual for employing this type of work in your clinical practice or for delivering it in workshop or community settings like you'll hear in a couple moments as Dr. Lilian Dindo did. You can pick up your copy of Radical Relief, available now on Amazon and in most countries. Okay, without further ado, let's begin and let's meet Lilian and learn all about ACT-based workshops. Hi, Lilian. Thanks for joining me this week on the podcast.
Hi, good morning, Joe. Nice to be here.
It's great to have you back on. For those who've been following along, Lilian was on probably just a little bit over a year ago. And coincidentally, before this episode today, I was chatting with a physical therapist who uses ACT in practice. His name is Davide Lanfranco, and he was on a couple of weeks ago. And after the episode was complete, him and I were chatting, and he was talking about some of the up-and-coming ACT research, and he was talking about many of the ACT researchers that are common in the literature. And he said, whose work do you follow with regard to ACT? And I said, I follow Lilian Dindo's research because her work is so groundbreaking as far as taking mental health approaches, taking evidence-based mental health approaches and moving them into the community where people need them, which is what we're going to be talking about today. Most importantly, we're going to be talking about a paper that was published in September of 2020, in the Journal of Behavioral Medicine. And it's called Combination Outreach and Wellness Interventions for Distressed Rural Veterans, Results of a Multi-Method Pilot Study. Obviously, you were the lead researcher in that, so we're going to talk all about that today. But let's start here. That pilot study is for veterans, specifically veterans with mental health conditions and mental health challenges. Tell us the mental health challenges that veterans have faced since the post 9/11 service era.
Sure. So the post 9/11 era that have been deployed to Iraq and Afghanistan have really high rates of distress-based conditions, PTSD, depression, generalized anxiety, sometimes you get confused when you're talking to them because it seems like it might be social phobia. It seems like it might be agoraphobia, but it's often really related to PTSD. You know, they've become hypervigilant to their surroundings, very avoidant of being out in the community. So there's a lot of PTSD. The rates range from 20% of that population to even up to 70% of that population having, some kind of post-traumatic stress. But relatedly, other forms of distress like depression and anxiety. Interestingly, this population has a really high rate of other conditions like mild traumatic brain injury and chronic pain. So this is often called the polytrauma triad in this literature because it's so common in this group of post 9/11 veterans. So, the mild TBI symptoms complicate the mental health symptoms. The chronic pain complicates. I mean, they're bidirectional, and there's this overall picture of suffering that can be very demoralizing and debilitating in this group of patients. And they often don't get very good treatment. They don't understand even what's happening to them.
Yeah. I think it's important to note that even though they suffer with PTSD acutely, I think what you're saying is they're still suffering from PTSD today. And
Absolutely.
that has been undertreated or in some instances not treated at all.
Absolutely.
Yeah, really important.
So the particular paper you're talking about, well, when I was doing a study at the VA, we would get qualitative feedback after our ACT intervention from veterans. And we would say, what do you think we should do to reach more veterans? Because veterans really like ACT. They resonate with the model. They resonate with the idea of connecting to values. We replace the word values with mission. We say, when you know what it's like to be committed to a mission and to engage in the mission, even when it's painful or difficult or scary. Well, now you're back stateside. What's your new mission? You know how to do this. You know how to do something that's hard because it's consistent with something that's important to you. And now what's new for you here? What's your new mission? What's your new purpose? How are you going to honor the people you've lost along the way by living a full and rich and meaningful life? So they really resonate with this idea, with the concepts in ACT, like values translate to mission. Mm-hmm. Acceptance really works in this population because you can't undo the memories, Joe. You can't undo some of the traumatic events. You can't change those. You can't undo some of the chronic pain they're now encountering. And so to tell them, like, this is it, it's here to stay, how can you suffer less with it, is a better approach, I think, than saying, let's figure out how to change this or get rid of it, right? Because they know that some of it is not to be removed.
Right.
So when we asked them, Joe, what do you think we should do? They would say to us, get outside of the VA. Go find people, because so many of them really dislike coming to the VA. It's a pain. Sometimes they don't trust the VA. It's impractical. There are many reasons why veterans often don't want to come to the VA hospital. And we just kept hearing over and over again, please do this out in the community. Please do this somewhere else. So that's what we did. We started teaming up with community organizations, actually universities that enroll a lot of veterans, vet centers, churches. I have a veteran that works with me that goes to trailer parks, Joe. He goes to bars. We basically just go out into the community and, try to identify veterans. And we actually do the workshop in a more benign setting. We've done them in universities. We've done them at vet centers. We've done them in community organizations. So it's more non-threatening that way.
So many great things that you mentioned there, and I want to touch base on some of those topics. The first one, which you brought into the conversation. So as I was reading through your paper, it's an academic paper, it's a research paper. But as you mentioned, there was that one line in there that you had that question. Once they completed that workshop, the question was, well, what's now? What is your mission now? And that just really got me. I mean, when I read that, I was like, oh, this is such a values-based contextual act question. And I love that you put that in the study, because all of a sudden, like the entire, like, even though I don't necessarily know what your intervention consisted of, right there, I was like, wow, this is really contextualized for the population that you're working, which I think is so important. The other thing, as you mentioned, there are barriers for anyone entering into the mental health system. A lot of it revolves around stigma, which is unfortunate. And, work like this helps to break that down, because everyone can benefit from some type of mental skills training, whether you've had trauma or not. But I think that the importance, and I want you to talk about this just a little bit, the importance of taking it out of the hospital, medical center, clinic. And you actually partnered with not-for-profit organizations that work with veterans and then delivered it there. And how important was that for the work?
It was critical for the work, actually. When we started out, we would reach out to different leaders in the community organizations. Like, I'll give you one example. The Vet Center in Beaumont. The head of that Vet Center in Beaumont is a guy by the name of Dr. Harris. And he was kind of distrustful of us and, didn't know what he thought of us. And we asked him, and he had a lot of veterans that would go to the Vet Center, either, for basics, like maybe for food stamps or for help getting jobs, for other purposes. They also do lead just basic educational workshops over there. So we asked him, I gave him a little presentation, for example, about what ACT is. And I asked him to give me a shot, to let me run one workshop with one group of his veterans. And he let us. And that was it, actually, Joe. The veterans loved it. And they went and told him, this is great. You should absolutely do it with other veterans. And so he became our biggest recruiter, actually. Anyone who came through the door for him, he would say, you need to do this workshop. Now, related to that, it's not called we don't call it a mental health treatment. So it takes away the edge of that, the stigma of saying, please go to this therapy for your PTSD, right?
So the word workshop is kind of the pivotal moment in almost all of this, correct?
Absolutely.
Yeah.
Never do we say we're going to do a treatment or a therapy. What we say is we are going to do a life skills workshop. Mm-hmm. That's it. We're going to try to teach you about some of the experiences that veterans encounter and how to better cope with them, with the hopes that this would enrich your life. That's it. I don't think we ever even talk about depression as a disease, mm-hmm. or post-traumatic stress disorder as a disorder, and so I think we really remove the stigma from coming to the workshop, right? You're coming to a class, you're going to a retreat, it's a class, you're with other veterans. And in fact, as the workshop leader too, one of the things that can be really helpful is to just be very human yourself. Who has not had anxiety? Yeah. And who has not been down? And who has not used short-term relief strategies, that haven't worked and have actually hindered life progress? And so there's, and again, and also, Joe, we start the workshop talking about what matters most to all of us in the room. So we're setting the stage, not talking about, I have depression, I have PTSD, I have chronic pain, but what's really important to me is my children and being the best possible mom and colleague I can be. What are the things we can do to move us in that direction?
Right. So now what my current problem is, not the kind of person I used to be. Where do I want to go from today forward?
Exactly.
Yeah.
Yeah.
I'm curious. So you mentioned, go ahead.
and we can talk a lot about, I really care about my children. I really care about my wife. I really care about my partner. But talk is cheap. And the child and the partner and your friends and your colleagues and your fellow veterans are not going to feel that you care unless you put that into action.
Mm-hmm. You mentioned you sit down with maybe the program director and you give them a little presentation about ACT. So
Yes.
they learn about ACT.
Mm-hmm.
Two things I'm curious about is, if you didn't have an opportunity to give a presentation, if you got a phone call and said, "Hey, I work in the VA center in New York City, and I heard you do these ACT-based workshops. Can you just tell me what ACT is in like a couple of sentences?" I'm just curious. I'm curious to know how you describe ACT to other professionals, or potentially if someone is seeking that type of service. And then two, do you ever mention ACT in the workshop at all?
It's a very, very good question, Joe. And we've been, that's one of the things, to be honest with you, the vet center, director, the people at the universities have asked us to create small videos actually to describe ACT. And we're working on that as we speak. And also to create like little informational brochures, infographics, they call them. So we're actually in the process of creating 1 to 2 minute informational videos, one set of videos for the community partners, and then one set of videos for the veterans, actually. So that is something we are working on because that's something they specifically asked us for. I have a hard time, I think, describing it in just 2 sentences. And so that's why I prefer to give a presentation where I actually walk through the processes of ACT and the philosophy of ACT. And so, but briefly, I tell them that it's not disease focused, it's not disorder focused, it's strength focused. We're trying to build on their strengths and to help them develop resilience. So the term psychological flexibility is too jargony, I think, for the community, but resilience is a term people get. And in a way, psychological flexibility is resilience. So we talk about, so I will say things like we help people develop greater resilience by actually really connecting to the kind of life that would honor, the things that they've been through, like how do you live a life that honors the people you've lost along the way? What do you think you would tell, or what do you think a fallen soldier would want for you to, how do you think they would want you to live your life right now? Do you think they would want you to withdraw? And what would it look like to turn a page so that you're not rereading the same chapter of your book, that you're now opening up a new book? And we give you the skills to do that, and we help you kind of recognize what are some of the challenges and what are some of the behaviors that feel really good in the moment, but actually lead to really long-term negative impacts. So I don't think I've gotten really good, Joe, at describing it just very briefly. But they get the values piece, they get the acceptance piece. And I say, like, our brain doesn't work by subtraction. I don't ask my veterans to try to change their memories or change their experiences. I try to help them build on those experiences.
A lot of that resonates really well, I think, because instead of describing what I'm going to do to you, you're describing the benefits, strength, resiliency, more life, a fuller life, a richer life, your activities, your goals. I think those benefits are really important for us to, as professionals, to discuss with people versus, well, here you're going to come in twice a week. Each session you'll be here for about 50 minutes. and we're going to
Right.
talk about your thoughts. And it doesn't really land. We know that now. It doesn't really land well with people. People are like, I'm here because I'm struggling and my life is difficult. And I want your help creating a new life for me. That's what I want. Right?
You know what's fascinating, Joe? When we do qualitative interviews, the weirdest thing, how many veterans have said to me, you don't like try to like like I'm not trying to like comfort them. That do you know how many have actually said you rip off the band-aid to me?
Mm.
And I think there's something that's just very honest about that.
Yeah.
Like we're not trying to like minimize or decrease the amount of past suffering. We're saying this is it, rip it off, move forward, right? It's here to stay. And it's interesting that they've used that term. I would have never thought about it that way. But actually, many people have said exactly that. Like, you rip off the Band-Aid, you're not scared to tell us, what it is.
That's a great metaphor, though, for so much of our work that we do with people. Because it's like, well, are you willing to be with a moment or two of pain?
Exactly.
If this is going to move you forward, a couple miles forward in your life. So I love that. I think people, even in practice, can use that metaphor. Give us an idea of what this workshop looks like. So how many people, who's facilitating it? How long is it? Are there milk and cookies? What happens during these workshops?
Pre-COVID or post-COVID, Joe?
Oh, yeah. I didn't even think about that. Talk to me about pre-COVID first.
Okay. Pre-COVID workshops ideally are about 6 to 8 people. We've done more than that, and I don't think it's as good. We've done less than that, and I also don't think it's as good. There's something kind of really good about that 6 to 8 number. We usually start, depending on the population, we usually start at about 9 a.m. and we end at about 3 p.m. We do have lunch together. We buy lunch for everyone, and we have lunch all together as a group. We take small breaks, like little breaks throughout. But the way it starts is that, we go around the room and we say, tell me your name, what service of the military, what branch of the military were you in? Have you been deployed? Where were you deployed? And one thing that's really important to you. And we have a whiteboard. And then, so we go around the room and each person just says one thing that's really important to them, and we write it on the board. And, if someone says, for example, my son, then I might say, who else here has children? Are children important to anyone else? So by the end of that, so like you said earlier, Joe, it's not, the introduction is around values, right? It's not about, I have PTSD, I have depression, I have TBI. It's what's important to me. So we're setting the stage for values being front and center. And by the end of that, we have a list of valued domains on the board, which stays up on the board the whole day. And I think we've done 100 of these workshops over the last, several years, and the list of domains is the same, right? We as humans share common values, friends, family, a meaningful career, children, the environment. It's the same God, spirituality. It's the same list. And then we say, okay, this workshop today is about how to make these things important. How do we make these things that you just said important in our daily lives, in our moment-to-moment daily lives? And then we do the matrix. And, we talk about, okay, what are internal experiences? And so from the veteran perspective, so the word we're using for that, Joe, in the veteran population is invisible wounds. So there's this term in the military culture called invisible wounds of war. But we talk about them with veterans as the things that are painful that no one can see, right? Like the memories, the pain, the moral injury. That's a really important term in this veteran population. So that's the way we distinguish kind of the inside world. It's, look around the room. You can see the veteran has black hair, brown eyes, they're wearing a black shirt. That's the outside world. But you have no idea what this person has been through, or their history, or their background. You don't know unless you ask them, right? So that's the way we start to distinguish between the inside world and the outside world. And this is really actually important, I've learned, in the veteran population and in PTSD, because they have so many re-experiencing moments, right? So many difficulties have to do with them driving down the road, they hear a loud noise, and in a moment they're back in Iraq where, an IED went off. And so we help to kind of say, okay, if something like that happens, are you in the outside world or are you in the inside world? Okay, you're here right now. That's a memory that was from the inside world. You're here. So they can start getting better at noticing the distinction between the inside and the outside world, and how important that distinction is, and how many interpretations are automatic, and how many interpretations are based on their history and their experience of war rather than the current moment. Then we go on to the horizontal line, and we talk about, okay, we'd all love to be living a value-driven life. We'd all love to be the perfect mom, dad, sister, brother, partner. But there are things that get in the way. What are those things that get in the way? Well, anxiety, fatigue, my TBI, my PTSD. And so after we built kind of this basic matrix, then we do very experiential exercises. And those are, without a doubt, the most powerful, like to the point where like you have sometimes several people in the room like tearing up, right? I can give you an example if you want.
Sure. And as you do that, I'm just curious, are you facilitating this on your own, or do you have a colleague that's facilitating with you?
Usually the best way to do this is to have two people. Usually I do it with another person, and I find that to be most effective because, if I'm doing an exercise, then my co-facilitator can pay attention to what's happening in the room. If someone's not really connecting or feeling off, we can help kind of clarify things if we feel like one person wasn't very clear. So usually there's two.
And then tell us about an experience or a small little case from that workshop.
So I'll give you one example of an exercise that I feel like every single time we do it is very, very powerful. I ask for one veteran volunteer, and I stand right next to him. And I actually usually put my hand, I ask for permission, and I ask if I can put my hand, on his shoulder. And I'll say, tell me, what was one of the things you identified as something that's really valuable to you? And I'll give you an example. One veteran said that his daughter was very important to him, but that he hadn't actually spoken to her in many years. And so I take out like a sticky note, and I put daughter, and I put it on the wall. And then I'll say, tell me what about this is important to you. Like, tell me a little bit more about your daughter. I ask him, to describe her to me, to tell me what she means to him, what it would mean to him to be a good father to her. And what is one small concrete behavior he would have to do to like move forward in that. And for example, like this one veteran said he would actually have to call her after many years of not talking to her. And so I put that on a sticky note, and I would say, call her, and I'd put it back up on the wall. And then we would stand on the other side of the room, And I would say to him, okay, tell me what gets in the way of that. And he'll say, fear, she won't want to talk to me, anxiety. And everybody in the room starts helping him out, like giving him ideas, and I give each person one of the barriers, like, I don't deserve, to talk to her. She will reject me. I'm not good enough. It's not worth it anyways. It's never going to change. And I give each person a barrier. And then as I kind of have my hand on his shoulder, I'll say, okay, let's start walking towards calling your daughter. And I'll say, remind me why this is important to you. And he'll remind me why it's important to him. And then as he starts walking, I tell everyone in the group to start yelling out the barriers. You're not worth it. She doesn't want to talk to you. You're a loser. You're broken. And so as he's walking, he's hearing, these barriers. And so then I turn him around and I make him go back, not go towards his daughter, but go back. And I'll ask him what that feels like to turn away from what matters. And he'll respond, I'll ask him what it was like to hear those sounds, and he'll tell me what that was like. And so I'll say, okay, let's try this again. And so we start walking again. And then the voices are louder. I tell the people in the room to get even louder and more annoying and more obnoxious. And so then I turn him around again. And you see, when I turn him around, I tell the others to be quiet, because that's how it works, right? When you avoid something, you shut down the voices temporarily. So I keep doing that several times. And then I eventually say to him, what would it take? I mean, what are you going to have to do to keep going? Like, what are you going to have to do with these voices? And the idea is that they have to be there. Like, they're never going to shut up. But this is, in qualitative interviews, people always remember this exercise. And it combines all the processes of ACT, right? You're continuing to move forward, committed action towards a value, even in the presence of all these barriers.
There's diffusion happening there. There's acceptance. There's committed action of having to make the phone call or thinking about to make the phone call. Even just thinking about making a phone call can be an important first step. I love the way you're describing this. And I think this is important for mental health professionals who don't know ACT at all, as well as physiotherapists and other healthcare professionals who are looking to kind of seed just their practice with a little bit of this. What Lilian just described is not your typical, I'm sitting in a chair across from someone and we're talking about their physical or emotional pain. This is an experiential therapy where I'm up and active, the patient is up and active. And of course, as you're describing this group, I'm getting this, idea of like the tribal support that people feel from it, which I think is so important, especially with the group you're working, but I think with everyone.
I think it's so powerful for everyone, Joe, because the content might be different, but the idea is the same. Everyone can connect with like the idea that there's something I want to move toward, but boy, my mind won't shut up, right? My mind won't stop giving me all the reasons why I shouldn't do this.
Yeah. So of
and
course,
they do really kind of support, like after this exercise, like there's this like moment where everyone's like, great job, man. You can do this, man. Like, there's this.
Yeah.
And it's interesting, Joe, because as I'm touching this person on the shoulder, like I can feel the pain. Like you feel it experientially in the moment, like you're contacting how hard this is.
That's right. And even the fact that you're a mental health professional and, you don't have to massage someone or, mobilize an entire joint, just placing your hand on a shoulder or on their lower back or wherever's safe, wherever's okay for them, that makes them feel supported as they're going through this, in essence, an exposure to something that's uncomfortable is super important.
Exactly.
Yeah. So throughout the research, you of course measured things quantitatively, things like depression, anxiety, distress, everyone can read about those. Positive outcomes at 1 month and at 3 months, which is important. So you follow them for about 3 months. And then qualitatively, you've already read some of those qualitative descriptions that people described. But I just want to point out to people, one of the most important parts of this study was the acceptability for patients, that people found this therapy, this approach, this workshop to be acceptable with 4 themes. So the first theme was that the workshop met or exceeded participants' expectations. The second is veterans perceived the workshop environment as welcoming and interactive. You just mentioned that. The third is veterans reported using skills and knowledge from workshops after in their daily lives. So there was carryover. And then 4, most participants would encourage other veterans to attend this workshop, which you mentioned in the beginning, but I wanted to kind of bring that back. So people are saying, I like this, I enjoyed it, I use it in my life, and I think you should try it too, which is really important.
So, Joe, this was the most interesting thing about this study. So this was funded by the Office of Rural Health for 1 year. And they told us if we met our recruiting goals, they would fund us for another year and another year. In the first 6 months, we struggled. Oh, we struggled. We had a really hard time recruiting, and we did a lot of outreach work. We spent a lot of time connecting with the community. And then we finally had our first group, like I said, right? After we had our first group, Joe, like we can't keep up now because veterans are telling other veterans, community partners are telling other community partners. Actually, one day we showed up to run a workshop where we were told there would be 6 people and there were 23. We had to turn them away. Wow. Because we're like, we can't do this with 23 people. Wow. But I think that's the biggest, like, it's such an honor to feel like I don't even need to be recruiting anymore. Other veterans are telling veterans about this. You know, they feel like it's worth their time.
I want to just shift gears just slightly and talk about some research, just some of the research with regard to ACT and CBT. People may have noted in episode 197, I interviewed a psychologist, brilliant psychologist. Her name is Amanda Williams, does great work. She's done 2 Cochrane reviews on psychological therapies for the management of chronic pain specifically. So she's really just talking about chronic pain. The outcome of her latest Cochrane review was that there's sufficient evidence across a wide body of evidence that CBT has small to very small beneficial effects in reducing pain, disability, and distress in those living with chronic pain, and that CBT may be considered the gold standard for the treatment of chronic pain. Nothing too much new there, but that's what I'm quoting her directly from the study. She goes on to say, and I quote, evidence of trials of ACT are of moderate to low quality evidence, so we're very uncertain about the benefits of these treatments for adults with chronic pain. And as I read this, and we're very uncertain about the benefits, and then I'm reading research like yours, and my brain just doesn't comprehend what she said. And I pushed her on this a little bit on the podcast because I think it's important that we discuss this. And I don't want to necessarily get into the minutia of research and like stats and things like that, because I think that's dangerous for us as practitioners. But my question ultimately is, ACT is a form of CBT. It's another way to help people with their thoughts, feelings, emotions, and behaviors. Is that too harsh of an approach to say we're very uncertain about the benefits of these treatments?
So 2 things about that. First, I would like to kind of reiterate what you just said. ACT is a cognitive behavioral therapy. You know, they both have a strong behavioral component and they both have a strong cognitive approach. The approach in, traditional CBT of challenging thoughts, do you really replace negative thoughts with more adaptive thoughts, or are you really doing more cognitive distancing, which is the ACT approach? I don't think we know for sure that the traditional CBT approach of changing the thought, if you've actually really changed it, as much as if you've cognitively distanced it from it, right? So, like you just said, ACT is a cognitive behavioral therapy. Um, and so we have built on, we stand on the shoulders of some of that research. And I think we built on it in some really meaningful ways by like adding values,
Yeah.
what makes it worthwhile to do the hard work. And it has to be connected to a values. A lot of behavioral activation, like really traditional BA protocols now have added values to them. Because if you really dig into the traditional CBT literature, do you really need the C part? It's unclear. There isn't much data to prove, to support that we actually need the cognitive challenging piece. And if you look at the traditional BA literature, now they've added values because they find that actually heightens the findings. That's one piece of it. The other piece about low quality, moderate to low quality, that's a really important issue, and it's a complex issue because what's considered gold standard and high quality is, double blind randomized controlled trials, right? Now we can't do double blind in psychotherapy, okay? So you do single blind randomized controlled trials with very clear inclusion and exclusion criteria and, all these fidelity. I mean, there are very clear guidelines about how to do gold standard studies. And a lot of the ACT in chronic pain literature, so ACT is considered an empirically supported treatment for chronic pain as listed by the American Psychological Association. If you look at the studies that have led to that outcome, it is not actually RCTs. Right. It's a lot of effectiveness trials, which means, actually studies in chronic pain centers, in hospitals, in kind of more traditional clinical settings. Now, I would potentially argue that might be a better test of the model than, these very clean-cut inclusion, exclusion criteria that don't necessarily generalize to what's being seen in the clinic. So I think, yes, the ACT studies in chronic pain officially are considered lower quality than these gold standard RCTs. At the same time, these are the people and these are the settings that you actually see the patients, and it works in those settings. So
there's something else from her research that I wanted to bring in and relate it to your study specifically. And I think this is the most important part that people should kind of leave today's episode with. When we look at traditional cognitive behavioral therapy, specifically for the treatment of things like anxiety, depression, which you're a specialist in, which is what your study really targeted in certain ways, there's a 25% dropout. So when people start CBT for depression, anxiety, about 25% dropout, same as in physical therapy, right? This is a big concern because we obviously want our patients to finish a nice full course of therapy so we can reassess. Yet your study with this workshop, 97% of the participants, and you've run this workshop in multiple places, multiple different groups, 97% of the people are completing the entire workshop, which is incredible. And,
yes.
and then it goes to, and I know you're going to talk about this, but what does that really say about gold standards, that what we think is gold standard and what really we should be aiming for with regard to gold standard?
So I have a lot of thoughts on that because that was the whole reason why I did a workshop intervention. You're being, well, not you, but to say that there's 25% dropout rate is actually quite generous because the modal number of therapy sessions that people go to is 1.
Devastating. That's devastating, though.
1.
Yeah, that's
so most people actually go to 1 therapy session. and then don't come back. Number two, the mean number of therapy sessions is 4, right? So that was the data that led me to develop the workshop idea, right? I was like, okay, so most people go to 1, and the average number they get of sessions is 4. So the attrition rate is outrageous. So most people are not getting a full dose of, or even close to a full dose of the treatment. So if I do 1 day and do 6 hours, then I'm giving people more than they would usually get if they were going to go, to therapy. And 97% actually, Joe, is for this study. It's 100% in all my other studies.
Mm-hmm.
I have never, not until this study, had anyone leave the workshop ever, And so you get the entire treatment protocol. You don't walk away after 1 hour, and that's huge. The other thing that was huge about this that I don't know if I mentioned, sometimes it's kind of like a foot in the door, right? Like, especially with veterans that feel like it's so stigmatizing to seek treatment. Sometimes the people that came to this workshop, a large portion of them actually said to us afterwards that they decided to seek out more intensive treatment after that, right? Like, it took away the edge of the stigma. Yeah. But you can't have a gold standard treatment. It can't, in my mind, it cannot, and others have argued this too. It can't be a gold standard treatment if it's only like gold in standard clinical trials and not in clinic settings. Yeah. How can it be a great clinical intervention if no one is actually doing it?
Looks really good on paper, but when you put it to play in real life, it doesn't necessarily look so good.
And if it has all these inclusion exclusion criteria,
yeah,
how well is it going to actually reflect the population out there?
Right.
That's what I also really like about this particular study. We had hardly any exclusion criteria. We said, are you distressed? Let's go. These people had so many medical conditions, so many other issues going on. Those are the people that really need the help.
And this is why I believe was it the VP of the VA who tweeted your study and some of the results on it, which is
the deputy secretary of the VA actually created a video of it and tweeted it without even telling us.
It's a tremendous honor. I mean, people who, in the United States of America, the VA is the closest thing we have to a public health system that is organized in some way. So I think when, we're going to include a link to that tweet, so people can kind of click on it and share it around as well. But it's a tremendous honor because it shows that, hey, you had great results. And then the people you're working with see, hey, this is what we should be paying attention to. And we should have more of this, both in the VA and outside the VA. And as we talk about that, and I think about that tweet, why is this work important to you? And what would you like to see happen with this work that you really have created a wonderful foundation for?
I mean, the reason why it's very important to me is because I feel like there are so many distressed veterans out there. And they go to boot camp to get ready for a war. They get intense training to go out to war. And then they get no training on how to get back into community. They're not taught how to cope with all these symptoms that are naturally going to show up. How could you not have nightmares or flashbacks? Or how could you not struggle with moral questions about what just happened? And so for me, it feels so important to give them a kind of boot camp on return, right? What do you do with these emotions? What do you do with these thoughts that are going to show up? Why do we prepare them so well to go out there, but not to come back? Yeah. And what do they do with their wives, their children, their husbands, their partners? I mean, no one, that's another thing I should tell you, actually, Joe. More recently, I'm hearing this much more. the veterans are telling me, like, you should let partners come in. You need to talk to my partner, help my partner understand some of this, because they're really, like, I have veterans tell me that their partners have gotten PTSD just from their behaviors, their anger outbursts and so on. So my dream is for this to be more widespread, that we do it for people coming back, right away. Few weeks, a month. Like, that's another thing a lot of people said to me, like, you should do this right after people get back. So for me, it's a dream to kind of make this more widespread, but it's just basic education, basic life coping.
We've been speaking with Dr. Lilian Dindo. She is an ACT-based psychologist who focuses on how to help people improve their mental health. Lilian, it's been a pleasure speaking with you today. Let everyone know how they can follow you and your great work.
It was really nice to talk to you today, Joe. Thank you for having me. You can find more information about me on the Michael E. DeBakey Houston VA Medical Center website. You can also find more information about me at the Baylor College of Medicine in Houston, Texas website. And finally, Health Services Research and Development Center of Excellence, also at the Houston VA. You can also contact me via email. I'm happy to respond to emails anytime. I'm really good about email. And it's Lilian, Lilian.Dindo, Dindo @bcm.edu, Baylor College of Medicine.edu, or Twitter is @Lilian Dindo.
Excellent. So we, of course, will have the links to everything that Lilian just mentioned, and we will have her email there as well. You can find that on the podcast page at the Integrative Pain Science Institute. At the end of every podcast, I ask you to share this information with your friends, family, and colleagues who are interested in helping veterans and others by using evidence-informed acceptance and commitment therapy. And I especially ask you to share this episode with anyone who's a veteran or knows a veteran, because that's where this work is most important. Again, I want to thank Lilian for joining us once again. We'll be following her work really closely, and I recommend you do as well. I'm Dr. Joe Tatta, and we'll see you next week.
Thank you so much.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.